Welcome to the first part of Fundamentals of Nursing. I'm Dr. Catherine Prado Lefkowitz, and as I said, I'm going to take you through the whole nursing school experience. But we're going to do this in a stepwise fashion. I'm only going to give you a little bit of information on each slide and in each presentation so you can really think about what I'm saying, take notes, and try to relay it to the real world and the patients that you have seen. So let's get started. So as we know, Fundamentals of Nursing has a ton of information. So the objectives that we're going to review in this Fundamentals of Nursing course, we're going to talk about the different steps of the nursing process. We're going to explain how ethical principles drive nursing care. We're going to learn about legal documentation regarding end-of-life care and treatment, explore theoretical models and how they direct patient care. And that's going to be the first video. Then in the second video, we're going to discuss pain and how it directs patient care and comfort. We're going to discuss pain relieving measures. And then we're going to talk about communication techniques because you need to be a fabulous communicator in nursing, not only with your patient, but also with the healthcare team. And then we're going to talk about therapeutic diets and nutritional methods. And then we'll probably stop there. And the next slide, we're going to be talking about using ambulatory devices safely. And we're going to talk about oxygenation methods and their appropriate uses. And I ran out of room on this slide, but we're also going to talk about preoperative nursing care, perioperative nursing care, and post-operative nursing care. So let's get started. So the nursing process, you have probably heard about this. There are 5 sections to the nursing process. Remember ADPI: assessment, diagnosis, planning, intervention, and implementation. I'll talk about that. And then evaluation. So when we do assessments on our patient, this is the most important thing that we as nurses can do because we need to gather data on what's going on. Data such as your head to toe assessment. So you're going to be taking vital signs, you're going to be listening to the heart and lungs, and you're going to try to figure out the underlying problem. You're going to want to look at the charting from the nurse before you to see if there's any changes that are occurring. And if you do your nursing process assessment, diagnosis, planning, intervention, implementation, and evaluation the same time every way, you are never going to forget a system. I know nursing students in fundamentals, they have to do a head-to-toe pass-off, and we're going to review the head-to-toe. I enjoy the head-to-toe, but nursing students get so, I guess, anxious that they forget body systems. So if you do your assessment in the same pattern every single day, in the same way, you're never going to forget a body system. All right, the diagnosis. This is the patient's response to what is going on with the patient, such as if the patient is anxious. Now, these nursing diagnoses are standardized by NANDA, so I'm sure you all have your nursing care plan books that outline nursing diagnoses. We're going to talk about how to make a good care plan later on. Planning. So you're going to set a plan of action of how the patient will meet the goals you choose. And goals are what the patient will do. So goals are what the patient will do. The patient will walk 10 feet today without shortness of breath. Okay, that's our plan. Of course, they should be smart goals, right? The goals. So they need to be specific and measurable and time limited. So the patient will walk 10 feet today by 3 p.m. without experiencing shortness of breath as evidenced by pulse oximetry reading stays above 90%. Okay, so the plan, you're setting goals for the patient. Now the interventions, this is what the nurse does for the patient. So how are you as a nurse going to help that patient meet his goal? Are you going to be giving medications before he does the walking? Are you going to be consulting with other team members? Are you going to be assessing lung sounds before and after? Are you going to be assessing pulse oximetry before and after? So the interventions are what you as the nurse are going to do. So intervention and implementation, they can count as one. So implementation is actually taking charge and working toward the plan. And then evaluation. So this is why the goals need to be very specific, because when you evaluate it, you're going to ask yourself if the patient met the goal or not. So if we were very vague and said patient will walk today, well, okay, it's not very specific. But if we say the patient will walk 10 feet without becoming short of breath, with pulse oximetry staying above 90%, that's very specific, and at the end of the day, we can say, yes, the patient met that goal, or no, the patient did not meet that goal. So the evaluation, you either meet the goal or do not meet the goal, and then you have to choose new goals. So you might have to reassess. You might have to come up with a different nursing diagnosis. You have to come up with a different goal. You have to maybe do different interventions. So these all tie together, but it always starts with assessment. So nursing profession and ethics. You know, our profession is based on ethics. We're all supposed to work at the highest standard of ethical decision making and ethical actions. So who sets the standards for nursing profession ethics? Well, you need to be familiar with your state board of nursing. Now, not all state boards of nursing have the same rules and regulations that are found in the Nurse Practice Act. So if you move from California to Nevada, you better get a Nevada Nurse Practice Act, because each state is different in what nurses can and cannot do. So just know that the State Board of Nursing is the regulatory agency for nursing. You need to read your Nurse Practice Act. Now, I was the Director of Nursing Education for the State Board of Nursing in Nevada, and we are very serious about ensuring that nurses perform at the highest ethical standard that they can. I have seen many nurses come before the Board of Nursing for unethical behavior, and you do not want to be one of those nurses. Also in nursing, we always use evidence-based practice. We have to use the most current data and evidence that is out there, so you need to be continually reading nursing journals and looking for new nursing research that points to new evidence of how we do things. We no longer say we do this because it's always been done like this. We always use evidence-based practice. You should also be familiar with the American Nurses Association. It's usually called the ANA. And this group was established to provide the standards of care for the nursing profession. They set ethical standards for nurses. Now, I don't know if you know this or not, but if you are ever working in a hospital and there's an ethical decision, a real ethical decision, maybe it has to do with a minor or a patient refusing a blood transfusion because of his or her religion, but if they don't get it, they could most likely pass away. There's always going to be an ethical committee in your hospital or facility. And this committee is made up of varying healthcare professionals, nurses, doctors, social workers, whoever chooses to be on this committee. And they meet and they look at the evidence of what the most evidence-based practice standards are right now. And they are going to provide a recommendation. They're not going to tell the patient or the doctor what they can and cannot do. They are going to provide a scientific, evidence-based recommendation on how to proceed. So just know that you always have resources. If you find yourself in a predicament and you don't know what you should do, it's an ethical problem, talk to your nurse manager, and you can bring this to the ethical committee. All right, so I'm sure you have heard about these ethical principles. Nursing professors like to ask questions that have you think about what ethical principle is being violated or is being called into question. Autonomy means that the patient has the right to decide what treatment they will and will not accept. So the patient has the final say. Even if all the nurses and all the doctors are telling the patient he or she needs to do a treatment, the patient can refuse. And that is perfectly fine. That is their right. They have the autonomy to choose what is going to be done to them. And nurses have to uphold this choice by the patient. Beneficence. This means to promote good. So we're always doing the correct things. We're always trying to promote the patient's best interest. We're always trying to do good and not harm our patients. Now, non-malfeasance, the definition is do no harm, avoid causing harm. So this is why we check and recheck our medications before we give it to the patient, because we could actually do a lot of harm, as you know, if we give the wrong medication to the wrong patient. Justice means to treat everyone fairly. We do not provide extra special care based on sex or race or gender orientation or how much money the patient has. We provide the same level of care to all of our patients, regardless of who they are. Fidelity means keeping promises and to stay loyal to your patient. So if you say, I'll be back in 30 minutes, you better be back in 30 minutes, because this is building trust and rapport with the patient. And when the patient feels like they can trust you, they'll probably talk to you more, give you more truthful, in-depth information than they would if they do not trust you. So fidelity is keeping your promises and staying loyal to your patient. Advocacy. We need to advocate for our patients. If the patient refuses a treatment and the physician is not clear on why the patient doesn't want it, it doesn't matter. We are the advocates for the patients. We do what the patient wishes us to do, and we don't do what the patient does not wish us to do. And then veracity, to tell the truth. We do not lie to patients, and we do not give false reassurance. So if a patient asks, is the shot going to hurt? We don't want to say no, because we all know shots are not painful, but it will only last for a few seconds. So we do not lie and we do not give false reassurance. If we have a cancer patient who says, am I going to die? We do not say, oh, you'll be fine, everything's going to be fine, because the evidence and literature usually points to the opposite. So if patients are asking you questions about what's going to happen, if they're going to live, they're probably scared and they probably need someone to talk to. We're not just going to blow them off and say, no, you'll be fine, because we all know as nurses, this person might not be fine. So this opens the door for communicating with your patient to really understand where they're coming from. Are they scared? Are they anxious? Do they not have enough information from their doctor? Again, we can be advocates for the patient, call the doctor and say, your patient here has many questions that need to be answered by you. So these are ethical principles that you need to uphold and follow in your nursing career. Advanced directives. You as nurses need to know what advanced directives are, and you need to follow them. An advanced directive is where the patient self-determines, is under the Self-Determination Act, and we'll talk about that in a little bit. The patient has the right to make decisions about their own health care. An advanced directive, it's actually a fabulous tool. It allows patients to direct their care in advance. So if they're incapacitated, they usually have something written as a legal document on what they do and do not want. And this really makes it less stressful for the family as well as the healthcare team, because the patient has already identified what he or she wants if they find themselves in a position where they cannot speak to tell people what they want. A living will is a document that the patient draws up which indicate interventions that they do or do not want. This is a good thing to do, even if you're 20 years old. I know people don't like to think about death and dying, but it's very important that people draw up something so it's clearly written in black and white, and it decreases the burden on the family, because the family will be okay knowing that the patient has already made up his or her mind on what they want. A do not resuscitate, or a DNR. In the event of cardiac death, I do not want CPR, or I do want CPR, then you would not have a DNR. But just remember that to have a DNR and to have it hold up in the case of cardiac arrest, we do need a physician's order. So as soon as the patient is admitted to the floor, they need to tell their physician, I want a DNR, and then that will be placed as an order, and then the nurses can follow that. A durable power of attorney. Again, this is great to draw up when you're young and healthy. It's a legal document that designates another person as being able to make their medical decisions for the patient. This person doesn't have to be related to the patient. It's someone that the patient chooses, that they trust to make the best decision for him or her. So just remember, you always need to ask your patients if they have advanced directives, a living will. Do they want to be DNR? Do they have a durable power of attorney? Getting all this information when the patient first comes in, and hopefully they're alert and oriented and they can give you this information just in case something unexpected happens, then the nurses aren't looking at each other wondering what to do. HIPAA, we all know about HIPAA. It's a law that sets forth protecting patient medical records. So you are allowed to discuss patient care with other members of the healthcare team who is providing direct care to the patient. You can share medical information with family and friends only if the patient has signed a release of information for that person. If you look in the chart and there is no ROI, as we call it, you are not allowed to share any information until that patient signs an ROI for that specific person. We do not talk about patients in public areas, such as in the elevator or in the cafeteria or in the parking lot, because one, it's unethical, but two, you never know who's around you. You never know if a family member is in the elevator with you when you're talking about a patient. So we don't talk about patients except when we're actively caring for that patient, we're on the unit, we're working with the healthcare team. Electronic health records. Well, they're good and they're bad. The whole purpose of having EHRs was to have one system where your data is in this one system, and regardless where you go in the country, they can pull up your information. Unfortunately, now there are many companies who have their own EHR system, so it's not that easy. It's not that streamlined. Maybe someday we'll get there. But for you as a nurse, you need to use a strong and unique password. You never share your password ever, because you don't want somebody else coming in behind you under your password, under your login, charting on the patient, because it's a legal record. And if it's under your name, you're the one that's going to be called out for whatever is charted on your shift for that patient. We need to log out every time we walk away from our computers, because we don't want someone to access our account and start documenting. We don't know what they're documenting. We don't know if it's accurate or not, but now it's under our name. And you can only access charts for patients you are caring for. So if your neighbor happens to be in the same hospital you work in, but they're on a different floor, you cannot look up her medical record to see what's going on and to see the progress of her healing, because that is unethical. She is not your patient. You have no right to look at her medical information. She hasn't given you the right. And even if she gave you the right, maybe she could fill out an ROI and you can call up to the nurses on that floor and get the information you're seeking. But to just open someone's medical record because that patient happens to be there is unethical. And this also applies to celebrities or famous people. Don't even risk your license looking at other people's information if they're not your patient. All hospitals can track who logs into what and where. So just know someone's always watching. So just be safe and only worry about your patients on the shift that day and provide the best care that you can to them. Let's talk about unintentional torts. So unintentional, this means that this is an unintentional act that causes harm to a patient. Negligence and malpractice fall under unintentional torts. Negligence means failure to provide care that a reasonable nurse would have provided. So this is maybe giving a patient a pain medication while he's up in a wheelchair, and then he falls out of the wheelchair and injures himself. This is negligence on your part because you didn't ensure the safety of your patient, and a reasonable nurse would not have acted in that manner. So malpractice is usually defined by negligence by a professional nurse, where you had a duty to act but failed to act in the correct capacity, such as not verifying medication before you gave it, and you gave it and there was a negative outcome for the patient. So unintentional torts, unintentional. We didn't mean to do it, but for some reason it happened and there was wrongdoing or harm to the patient. Intentional torts, this is done with intention, is a willful act that violates patient rights. Assault. If you assault somebody, by the legal definition, you threaten them. Such as, if you don't stop acting up, I will tie you down. That is a threat. Then battery is touching of a patient without consent that causes harm, such as administering medication that the patient refused. So the way to remember this is A before B. The assault or the threat is made before the battery. So A before B, assault before battery, threat, and then action. False imprisonment is very up there these days in patient rights. False imprisonment means keeping someone against their will, such as putting a patient in seclusion without an order, or if the patient is trying to leave AMA and you block the door and don't let them out. False imprisonment is huge, like I said. Joint Commission is huge on this right now. We don't restrain patients for the convenience of the nurses. We don't give medications to patients that the patient has already refused because patients have autonomy. So just make sure when you are restraining a patient, it is done correctly with a doctor's order. You've tried least restrictive measures first. The patient is a harm to himself or someone else. We don't tie people down because they're quote unquote a nuisance or keep getting out of bed. We need to think outside the box. Maybe put a mattress on the floor. Maybe put the patient in a room closer to the nursing station so that the nurses can keep eyes on him at all times. Then we have defamation of character. This means making derogatory remarks that harm a reputation or has the potential to harm a reputation. Under this falls slander and libel. Slander is any defamation of character that is spoken, such as gossiping untruths about people. So slander starts with an S, and it's about speaking. We have to speak this out loud. Versus libel, this is any written falsification about a person, such as posting it on Facebook, hanging up signs, handing out flyers. This is libel, and it's written down, versus slander, which is spoken. Nursing students always ask about abandonment because they don't really understand abandonment. You can only be accused of abandoning a patient is if you desert a patient when you should be taking care of the patient, such as you go to work, you get report, you have a patient load, you decide to leave and go home 6 hours later, but you don't let anybody know, you don't hand off your patients to another nurse, and you just leave. You have just abandoned your patients. However, if you go into work and you refuse to clock in, this actually happened in a facility recently, you refuse to clock in because the patient-nurse ratio is unsafe, then you don't have any patients. You haven't accepted any patients. So you cannot be accused of patient abandonment. You can only be accused if you've received a report, you're now responsible for their care, and you leave without letting anybody know. Mandatory reporting. Our job and duties as nurses is to be mandatory reporters. We need to report suspicion of abuse of a child, a vulnerable adult, or an elder. You do not need proof. All you need is a suspicion of neglect or abuse. Of course, your documentation needs to be pristine. You need to document about the suspicious injuries, document what the patient's account is of what happened, and then look at the injuries. If they don't match, of course, you're going to document what the patient told you, and then you're going to document the injuries, and then you're going to call either Child Protective Services or Elder Protective Services. The priority nursing action is to protect the patient from harm. The goal is to interview the patient and suspected abuser separately. Now, if we're talking about a 26-year-old female who is in a domestic violence relationship, she comes into the ER or the hospital frequently with broken bones, black eyes. We are not mandatory reporters for her because she is an adult and she's not a vulnerable adult. All we can do with this patient is to let her know of her options. She can report the abuse to the police, but our job is to help the patient think about developing a safety plan. And of course, you want to provide information on shelters in the community or refuge houses if she decides to leave. But we cannot call the police for her if she says, no, I don't want you to call the police. Then we just provide resources. We educate her that nobody deserves to get hit or beaten. We give her addresses of shelters or safety homes that we know about in the community. So just know, children, vulnerable adults, and elderly, we have to report our suspicion. Our documentation needs to be 1000% correct, and we're going to describe what the patient says, and we're going to describe the injuries that the patient came in with. Most nursing students, I don't think, are exceptionally excited to learn about theoretical foundations, but there are 4 that you should really, truly understand and put your focus into. And this is Kohlberg, Erikson, Maslow, and Piaget. And the reason I say this is because many NCLEX questions might allude to these theoretical foundations. It might not say, what does Kohlberg study? But you need to know if the question is asking about developmental stages, where they should be, how they learn, how their thinking is progressing. You need to know the concepts between Kohlberg, Erikson, and Maslow. Let's talk about theories that guide our nursing practice. So Kohlberg is somebody you need to know about. His research was all about thinking, reasoning, decision making. Kohlberg has stages, and they're sorted into 3 levels: pre-conventional morality, conventional morality, and post-conventional morality. Each stage involves a more advanced level of reasoning that coincides with the cognitive development and life experiences. So level 1 is the pre-conventional morality, and this is one of the most basic moral development skills. In this level, moral reasoning is based on externally controlled rules that are handed down from authority figures. So these are pretty young children. They don't have a lot of life skills yet. They don't have a lot of abstract thinking abilities. So they pretty much do what authority adults tell them to do. Then they should be moving into level 2, which is conventional morality. And conventional morality begins to emerge around the age of 10 or 11 and is characterized by accepting the rules of various social groups. So if you know about 10 or 11-year-olds, they start making friends. They start having arguments with friends at school. They start having BFFs. They start having no BFFs. So this is characterized by accepting the rules of various social groups. So they're learning about society and how to fit in with society and how to stick to the societal rules and regulations that adults live by. Stage 3 is establishing good interpersonal relationships. The moral decisions are based on how they affect interpersonal relationships. So the 10 or 11-year-old might not have much self-control. They might be a little mean to each other. But when you move into the conventional, which happens about 13 on, they start thinking about how their actions are going to cause interpersonal discord and how to stay away from causing interpersonal discord. So they start developing abstract thinking skills, thinking into the future. If I do this, what could potentially happen? Do I want that to happen? No, so I probably won't do that. So the pre-conventional is usually less than 5 years old, where you get a reward or not get a consequence because you're listening to adult authority figures. Conventional is 6 to 12. You think about how your actions affect people, but you really don't care. It's not that you don't care, you don't have enough life experience to understand the consequences. Post-conventional is 13 on, where you're developing abstract thinking and think about the world in a more complex ways. Next, let's talk about Maslow's hierarchy of needs. Now, this is something that you truly need to understand because the way you answer NCLEX questions usually has to follow Maslow's hierarchy of needs. There are many needs for human beings. So we have physiological needs all the way up to actualization, self-actualization. We cannot do higher level things unless we meet lower levels and that they are met. We can't worry about love and belonging without basic needs. If we don't have a house, if we don't have a job, if we're living in our car, we can't be worried about increasing your self-esteem when your circumstances don't allow it at this time. So Maslow's hierarchy of needs, you usually use this when reading NCLEX questions because it's not going to ask directly about Maslow's hierarchy of needs, but it might incorporate, somebody's fear of dying because they have a terminal illness. Well, you're not going to be focused on their self-actualization at this point. You're probably going to be worried about their physiological and safety needs. Hopefully they have some loved ones in their life, but we're not going to worry about self-esteem or self-actualization when we're at the lower level on the hierarchy of needs. Erikson. I'm sure you've heard about Erikson. Again, you need to know Erikson because this might be a test strategy that you can use. So Erikson talks about stages in human development. And each stage, you have a psychological crisis. So, he has 8 stages. I'm just going to review the highlights here. But in the infant stage, you go through trust versus mistrust. When I cry, does somebody come? If somebody comes every time, I'm probably going to trust that someone is going to respond to my needs. If I cry for days and days and nobody comes, I'm probably going to be very mistrustful of people as I get older. School-age kids, industry versus inferiority. So they like to do crafts, that's how they learn. But if they're in the hospital, you need to understand that at this stage is industry versus inferiority. So it's very easy for these children to start feeling inferior if they're not able to hang out with their friends or not go to school, not finish projects. So understand that they are away from their peers and away from their learning environment. So you as a nurse might ensure that they get their homework and that they're able to complete lesson plans or lessons for that week in school. Maybe suggest that one of their friends comes to visit them so they're not feeling like they're inferior and not industrial, getting things done. Then from 40 to 65, we have generativity versus stagnation. So usually more toward the 60s, you know, or maybe 50s, you know, your children are leaving home, they're going to college, they're creating their own life, you've retired, and you're living your life in a new way. So either you love seeing your children leaving, you love being a grandparent, or you're in crisis. And I'm trying to hold on to my youth. So these are assessments you need to make with your patients so you can understand where they are. If they feel stagnant, maybe they need to talk to somebody. Maybe they need to be reminded of all the things that they have done in their life and that this is a new life phase for them. And we go through phases our whole entire life, from, you know, infant all the way up to death. So this is just a new phase, and the patient has to understand that and find coping mechanisms where they can feel that they've done good things and that they should be happy for their children getting married and starting their own family, because it might be sad, but that's the way it's supposed to go. So this is a good assessment that you need to make with your patients. I put this table in here so you can see all 8 stages and what they are and what happens in that stage. Just make sure that you understand just kind of the concepts of how people move from stage 1 to stage 8, and how you can identify where your patient should be, and then you can identify if they're coping positively or negatively. Piaget. Piaget worked on perceptions and cognition. He wanted to know how children learn about the world, because we know that kids see and experience the world in many different ways. Ages 0 to 2, if you have children, you know that children explore through sensory motor. So senses and moving, they're touching everything, they're starting to crawl, they put things in their mouth. They're starting to learn a little bit about object permanence, meaning if I move an object out of sight, the child knows it still exists. Then we move 2 to 7 into pre-operational stages, and this is where children usually have magical thinking. They believe magic is real. They make inanimate objects seem like they are alive, such as having their favorite stuffed animal that the child cannot sleep without because the child's worried that the stuffed animal will be lonely. 2 to 7 is also a great time to take your kids to Disneyland because they believe in magic and it's just so magical for them, and they have a fabulous time. Then we move from 7 to 11. This is concrete operational. So this is more based on conservatism, so that they start understanding when we transfer objects from one container that's really big to another container that might be smaller, they understand that the amount has not changed. So 7 to 11, more concrete operational, and they're learning conservatism. And then from 11 on, their abstract thinking is developing. Of course, they're not going to have the same abstract thinking abilities when they're 45 that they do at 11, but they're starting to put pieces together, and the expectation is that they continue to learn and grow and have more and more abstract thinking as they progress through life. Here's another table I provided you. Again, about the stages that Piaget studied, the age ranges that go with each stage, and kind of what happens or is expected to happen in each stage. Good thing for nurses to know, because if we work in pediatrics, we need to understand where they should be in terms of their age and their stage. If they're not where they should be, then you might have to consult with a healthcare team to get the child assessed further.